Today we are learning about antidiuretics. Antidiuretics are drugs that reduce urine volume, primarily used in a treatment of diabetic insipidus to control excessive thirst and excessive urination. Classified into mainly three groups: antidiuretic hormone and analogs, thiazide diuretics, and miscellaneous drugs. Antidiuretic hormone and analogs: vasopressin, desmopressin, which is a drug of choice, lipressin, and terlipressin. Thiazide diuretics: paradoxial action in diabetic insipidus, for example, hydrochlorothiazide amiloride, specifically for lithium-induced nephrogenic diabetic insipidus. Miscellaneous drugs: chloropropamide, oral hypoglycemic that sensitize kidney to ADH, carbamazepine, anti-epileptic that stimulate ADH release, NSAID, indomethacin. Vasopressin is synthesized in the hypothalamus and secreted by the posterior pituitary. Desmopressin is a synthetic analog of vasopressin. It is highly preferred clinically because it is highly selective for V2 receptor, minimal V1 vasoconstriction action, and has longer duration of the action. Mechanism of action: vasopressin acts on a two distinct G protein coupled receptor. V1 receptor is a GQ coupled, V2 receptor is GS coupled. So V1 receptor is present on a vascular smooth muscle. Activation increases intracellular IP3 and DAG, leading to calcium release and profound vasoconstriction. V2 receptor, which is GS couple, present on the basolateral membrane of the collecting duct principal cell in the kidney. Activation increases the intracellular CAMP, which causes translocation of aquaporin to water channels from intracellular vesicle to luminal membrane. Dramatically increases the water reabsorption from tubular lumen to blood, concentrating the urine. V2 receptor are found in a collecting duct principal cells in kidney, um, which increases the intracellular CAMP. CAMP leads to translocation of aquaporin 2, which is a water channels. Aquaporin 2 translocation from principal cells to luminal membrane, which leads the H2O reabsorption, water reabsorption, and tubular lumen to blood, which leads the concentration of the urine. Now, therapeutic use is used in a neurogenic diabetic insipidus. Desmopressin is the drug of choice, administered orally, intranasally, and parenterally. Desmopressin is commonly available as nasal sprays and oral tablets. Nocturnal enuresis, bedwetting. Desmopressin nasal spray or tablet as bedtime reduces the urine production overnight. Hemophilia A and von Willebrand disease. Desmopressin induces the release of factor 8 and von Willebrand factor from the vascular endothelium extrarenal V2 receptor. Bleeding esophageal varices. Terlipressin and vasopressin is intravenously is used. These stimulate V1 receptor, causing splenic vasoconstriction, which dramatically reduce the portal vein pressure and stop bleedings. Adverse effect: water intoxication, hyponatremia. The most serious ADR causes headache, drowsiness, confusion, and potentially fatal seizures. V1 mediated side effect, mainly with vasopressin, rare with desmopressin. Ischemic heart disease like angina, myocardial infarction, hypertension, abdominal cramps, gut spasm, and facial pallor. Nasal irritation, congestion, and ulceration with nasal spray. Thiazide diuretics as antidiuretics. Using a diuretic to treat polyuria sounds paradoxical, but thiazide like hydrochlorothiazide are the drug of choice for nephrogenic diabetic insipidus, where the kidneys are completely unresponsive to ADH or desmopressin. Mechanism of paradoxial action: thiazide inhibit the sodium and calcium importer in the distal convoluted tubule, causing initial sodium and water loss, mild diuresis. Second, this induces a state of mild extracellular fluid volume depletion. Volume depletion triggers a compensatory increase in the reabsorption of sodium and water in the proximal convoluted tubules. As a result, less water is delivered to the distal nephron and collecting duct, paradoxically reducing the total urine volume by up to 50% in nephrogenic diabetic insipidant patient. Specific use is amiloride, a potassium sparing diuretic, is specifically preferred for lithium-induced nephrogenic diabetic insipidus because in it blocks the entry of lithium into the collecting duct cells. Miscellaneous antidiuretics: chloropropamide, carbamazepine, indomethacin. Indomethacin is a NSAID. Chloropropamide, an oral sulfonylurea that sensitize the renal V2 receptor to trace amount of endogenous ADH, can cause severe hypoglycemia, used in a mild cranial diabetic insipidus. Carbamazepine, an epileptic drug that stimulates the secretion of endogenous ADH from the pituitary, neurotoxicity or ataxia. Indomethacin, renal prostaglandins normally antagonize the action of ADH. Indomethacin inhibits the prostaglandin synthesis, thereby enhancing the ADH action. Gastric ulcer, renal toxicity, most used in adjunct in nephrogenic diabetic insipidus. Thank you.